Okay, so I've turned on the record button at this point, and I will get us started. So I am Kristen Lindgren. I'm one of the co-directors of Trauma Recovery Innovations research group at the University of Washington in the Department of Psychiatry and Behavioral Sciences. And I'm joined today by Dr. Michelle Bedard-Gilligan, also co-director of Trauma Recovery Innovations, and Dr. Emily Dworkin, core faculty member of Trauma Recovery Innovations, and we will be leading you through the training today. I want to thank you for the opportunity to be here, and as we said earlier, we want to thank Molly Forrester for the invitation. What our plan is today is to give you a primer on skills for psychological recovery, and this is part two, in a sense, of a series that we're doing on mental well-being and resilience interventions for individuals who are affected by mass disasters, including things like global pandemics, like coronavirus. And before we get started, we do want to acknowledge the treatment developers of SPR. So SPR was not something that we created, but what we are doing is distilling it down and trying to break apart what is typically a 5 to 6 hour training into about an hour and a half to give you an overview of what SPR looks like. So SPR was developed by the National Centers for PTSD and the National Child Traumatic Stress Network, and we're able to do this and bring this to you because of support by our department, by this Department of Psychiatry and Behavioral Sciences. And in particular, we want to thank Molly Forrester and Rebecca Sladek and Rosemary Whitwright, who've been helping us with all the technical assistance to bring these materials to you. So with that said, and moving forward, what we want to do is give you an overview of what we're going to be covering today. We're going to start with background and rationale, give you a feel for the various components of SPR, and then we'll wrap up with an overview of resources that we'll be making available to you. Our goal is to take about 75 minutes to do that, and then we'll have about 15 minutes for questions at the end. We do have the chat up and running, so if you do have questions and want to be raising them as we go, please feel free to chime into the chat, and Michelle will be taking the questions in the chat, and if something ends up coming up that we need to pause and stop and bring it out to the whole group, we're happy to do it, and if not, Michelle will be sending out answers as we go through it. So as we get started, and you are absolutely welcome to take screenshots as you go along. I did see that question pop up. So as we go through, in terms of background in SPR, we really wanted to start by giving people just a basic background into why we're talking about these kinds of interventions, why we're talking about interventions that are brief, why we're talking about interventions about promoting resilience. And one of the things that we want to do is really remember that when we're thinking about pandemics like COVID-19, we think about this as a chronic stressor, right? And so if you see our graph up on the slide right now, that's punctuated by periods of acute distress and then some relief from it, and then acute distress again, and then relief from it. And what we want to do with SPR is to give people a way to navigate through these times of distress and prepare them from them, because one of the things we know is that the most common outcome when we're thinking about acute crises and stressors like this is in fact resilience, but that resilience doesn't mean that there isn't distress along the way, and that we found that there are things we can do, skills we can learn that really can be helpful and prepare people and help them navigate this time. And so that's why we talk about interventions like psychological recovery that we've presented to this group in the past, psychological first aid rather, and then skills for psychological recovery that we're talking about today. So when we think about SPR, what SPR is is that it is an intervention to promote resilience. And a key piece, because a number of you in this audience have heard us talk about PFA or psychological first aid, is we want to be clear that this is different from PFA. When we're doing SPR, what our assumption is, and where this fits in terms of putting in an intervention in terms of a mass disaster and recovering from a mass disaster, is the assumption that basic stabilization has already been achieved for individuals. So with SPR, we think about this as an intervention that can be used once stabilization has been achieved. It's for used in later phases or even the aftermath of a crisis. It's something that can be used even months or years after a crisis is over. And it's really intended to consist of multiple sessions of skills building. And so what we want to do when we're using an intervention like SPR is we want to protect the mental health of people who have survived some kind of crisis. We want to enhance their abilities to address their needs and concerns. And we want to teach them skills that can help them promote recovery. And one of the things that's really exciting about SPR is that this is an intervention that can be adapted for children, for adolescents, for families. And what it does is really seeks to prevent maladaptive behaviors from developing while identifying and supporting or building adaptive behaviors that people already have. A key piece about SPR that is important to know is that SPR isn't a treatment for mental health disorders. It's for individuals who need more help than PFA. So for example, when we used to talk about PFA, we were talking about this ultra brief intervention that was at most consisting of 2 contacts, but more typically 1 contact. So SPR is meant for individuals who need more than that and a little bit later in the crisis, but it's also not meant for individuals who have full-blown psychopathology, full-blown mental health disorders. You might think of it as really kind of meeting in that middle ground when individuals have a mix of strengths and distress. It's frankly a place that many of us may have found ourselves or our loved ones for various periods. And so we want to be really clear that PFA isn't therapy. It certainly can be done within a therapy or clinical setting, but it doesn't have to be. And we also want to be clear that it's not focused on psychopathology. The emphasis is really on finding and building strengths and teaching skills. And we also want to be clear that it's different from other kind of approaches like psychodynamic or psychoanalytic exploration, where we might be thinking a lot about the past. Instead, SPR is skills-based, it's present-focused, and also it's not psychological debriefing, which again may be something that individuals have heard about. And psychological debriefing is or was an intervention that was developed for acute crisis that consisted of having individuals talk in great detail about the worst parts of traumatic events that they've been through. And what we've actually found is requiring people to talk about that can actually be iatrogenic. In other words, it can actually make people worse. So that's not what SPR is. SPR is skill-based. You might talk about the specifics of what happened with individuals, or you might not. And there really is flexibility in the application of SPR. So that's what SPR isn't. So let me tell you a little bit about what SPR is. So it is, in fact, evidence-informed. And what we mean by that is that the principles or the targets that come up and are embodied in SPR are really coming from a body of research about trauma, about risk, about resilience, about what we know that works for individuals who've had those kinds of experiences. It's also incredibly flexible and practical. As I alluded to earlier, it's something that you can do in a mental health or non-mental health clinical setting, and you can also do it in non-clinical settings. We've certainly heard, and SPR has been implemented in community kinds of situations when we think about the range of disasters that people can experience. SPR is absolutely appropriate for individuals across the lifespan. It can be used also with families. And a key piece that we want to emphasize is the importance of applying SPR in a way that is culturally aware, in a way that is culturally mindful. And so what SPR asks of us as interventionists, if we were going to be using SPR, is that we are in fact aware and mindful of the individual's cultural backgrounds, cultural experiences, their various identities and intersecting identities, and that as we adapt and implement skills, that we're doing it in a way that is consistent with individuals' backgrounds and experiences so that it's useful for them and acceptable. Because we've talked about PFA with this group, we did want to make sure we were clear about how SPR and psychological first aid differs. And as we talked about, and I alluded to earlier, among the differences is that SPR is administered in the later phases of a crisis. It does presume that physical safety needs have been met. It also differs in that SPR typically consists of multiple sessions, whereas PFA is typically done in only a single session. And if we think about what our goals with psychological first aid are, it really is about stabilizing individuals, whereas SPR is really about teaching specific skills with the idea of promoting self-efficacy, self-esteem, reducing distress, and building skills so that people are able to move forward and really recover from the disaster that they've been through. While SPR is a wonderful intervention and something that Michelle, Emily, and I are very excited about, something that we think might be useful to you in your clinical practice or with the COVID support groups, we want to be clear that it's not appropriate for all situations, right? And so one thing we want to be mindful of is that even if many people are in the chronic phase of a crisis, it's possible that you might be working with somebody and realize that they are still in an acute phase. And so in that circumstance, SPR wouldn't be appropriate, and we want to think about a different kind of intervention to be helpful. We also want to be clear that some individuals might present to us, and what we realize is they actually need more help than brief interventions, right? And so when you see situations where a person has safety concerns, whether it's danger to self or danger to others, that's a place where we would want to think about either referring out, or if we have the skill set that's needed, that's appropriate, actually doing a more intensive intervention. And we also want to be clear that SPR isn't appropriate in situations where there's acute psychosis, severe cognitive disabilities or cognitive impairments, or frankly, severe mental health concerns. In those cases, I would want to use our evidence-based interventions at that point. When we think about SPR and how you actually implement SPR, for most of us who've had experience with behavioral or mental health, this is our bread and butter skills. And the same things that we would do in the types of psychotherapy or medication management that we practice, we want to bring them to bear with SPR as well. We want to be looking at and using our active listening. We want to make sure that our empathy and validation skills are being brought to bear. And as a reminder, what we're really looking to do is really be on the lookout for and reinforcing individuals' strengths, looking for opportunities where we can build them and reinforce the strengths that are already there. And then again, we want to bring attention to individuals' identities and cultural backgrounds, making sure that we're aware of them, that we're humble about our knowledge, and making sure that the skills practice that we develop is consistent with their backgrounds and useful to individuals' backgrounds. As we go through what SPR actually looks like and the specific skills, you may notice that there are some similarities between cognitive behavioral therapy and SPR. It certainly is consistent with some of those principles, though it is not CBT per se. Some of the things that you may notice where there are similarities is that SPR is in fact focused on the present moment rather than looking for interpretations or looking at past experiences and how past experiences inform the present. Like CBT, SPR emphasizes skill building. And like CBT, what you'll also notice is that SPR has assumptions and focuses on the interconnection between thoughts, emotions, and behaviors. And we assume that those things are interconnected. As we implement SPR, one of the things you'll notice is that SPR consists of 5 individually tailored skill modules, and we're going to be going through them over the course of the training. One of the things that's really fun about SPR and gives you a lot of creativity with it is that you're only going to be teaching and using skills that are relevant to the individual that you're working with. And so as we go through the training, we'll walk you through how you do each of those skills, specific strategies for teaching problem-solving skills, strategies for promoting positive activities, for managing reactions to distressing events and the crisis that people have been through, ways to help people promote helpful thinking, and then also some skills to help people rebuild social connections that may have been impaired or affected in some ways by the crisis that they've been through. When we go through and we think about what a course of SPR looks like, right, because SPR, unlike PFA, is going to include multiple contacts, it is both flexible and structured. So you're really going to see a dialectic between the two. And what you'll notice with it is that the first session is relatively structured and that it consists of doing some introductions, building rapport, assessment, and treatment planning. And it includes teaching and practicing the first skill. What follows in multiple sessions are reviewing homework, reassessing how the skill implementation worked, and then teaching and practicing either the same skill or a new skill. And you're going to do 1 to 5 sessions as needed. Where the flexibility comes in and where the creativity really comes in this really fun way is that you're going to be tailoring and selecting skills based on the presenting concerns that individuals bring to you when you're working with them. So giving you a little bit more of a feel for what a typical first session of SPR would look like, it consists of basic meet and greet kinds of skills, doing some collaborative assessment, understanding what the person is coming in with, and then based on those concerns that they have, selecting skills that will meet that. You know, you'll notice that SPR is brief. We're talking about 1 to 6 sessions tops that you'd be doing with SPR. So you're not going to be able to address everything that people are coming in with. So this really is a place where we're going to be working to prioritize the biggest concerns, and that's what we're going to focus on and use that as a way to really leverage and jumpstart people's abilities and their existing strengths. What we do once we have a feel for what the priorities are and what skills would be useful, we start by teaching a new skill. We do that in the very first session, so it is a really efficient use of time so those of us who might be used to more unstructured kind of contacts with people. This may force us to really watch time and do great time management. You're going to have that sense of I could go deeper, I could go deeper, I could go deeper, and you certainly could. If you were doing true psychotherapy, you would. But again, this is different from psychotherapy. We want to really push on that skill development as quickly as possible. And so with that, we're going to learn to present rationales for new skills very briefly, how to teach and practice a new skill within that session, and then assign homework or practice outside of session so that individuals get an opportunity to implement these skills as quickly as possible. Again, you know, really with this eye towards what we're wanting to do is start those skills, build resilience, and really help people recover. And we follow that, of course, with a summary of what we've done and what the plan is for follow-up. When we think about what the follow-up sessions look like, what they consist of is, in fact, reviewing homework. You know, how did the skill practice go? After that, there's, again, this collaborative assessment and skill selection. And when we think about that, often what our decision points are about is, are we going to keep using the same skill, potentially because we need more practice with it, it didn't go as well as we hoped or thought it might, or you might find that there's a different domain in which the person wants to apply the skill and practice the skill, and so they want more opportunity to dig into it, in which case then you would continue to work with that same skill and assign homework and really figure out how you're going to tailor it to this new domain, or help them practice and build the skill up even further. Or if the person has gotten what they need out of the skill and the basics have been met, then we move on to teaching a new skill. And again, anytime we teach a new skill, we want to make sure we're presenting an explicit rationale for why we're doing this. What's the reason that this particular skill is being introduced? How is it going to be helpful? We, again, want to teach and practice it. And we follow up with assigning homework. And then every session would end with, again, a summary of what we did, why we did it, and then follow up, really being explicit and really thinking that our stance when we're doing PFA is much more like a coaching session than what many of us might be used to different kinds of psychotherapy contexts looking like. The final session of PFA, as you'd expect, it's again going to begin with reviewing homework and practicing skill. From there, we're going to move into, again, thinking about and reviewing the rationale for all the skills that have been taught over the course of PFA. And we also want to check in and review accomplishments, right? So what did the person learn? How did they implement these skills? What got better? So that we're, again, really looking for those strengths and really reinforcing those strengths over the course of contacts that we have with individuals. And then again, we want to be on the lookout for places for continued practice. When people complete SPR, they're not all done in the sense that they're still going to have work to do. And so we want to really help think through with them, how else can you use this skill? Where else is it going to be helpful to you? What else do you want to be on the lookout for? And we also want to make sure that people know what they can do and how they could get more help should they need help in the future and going forward. So I want to walk you through what the very first phases of SPR look like in terms of assessment, and how is it that we're going to do this when we're trying to get people in and out and restore to functioning as quickly as we can. So our first step with PFA when we're doing assessment, once we've introduced ourselves and the person that we're working with has introduced themselves, is to get a feel for needs and concerns, right? And so what we want to make sure that we're really clear about is what's bringing the person in. What are their top priorities? And when we think about that and we think about the rationale for why we do assessment, because this is something we're even clear with the individuals that we're working with about why we do this collaborative assessment, and we want to talk explicitly with them as a way to normalize and help them understand that for most people, when they go through acute crisis periods, that people are going to have distress afterwards, right? That they've had experiences that have been really difficult to go through, that they may have had losses. And so as a result of that, that they may need assistance, right, with immediate or longer term medical or mental health concerns. They may have different hardships or adversities that are going on for them. They may have some residual concerns about safety or be experiencing difficulties in functioning, whether it's interpersonal functioning or role functioning. And so by gathering information, right, and figuring out what the priorities are, this is a first way to actually move from being overwhelmed into actually having concrete problems that we can solve. Okay. Again, one of the things that we want to remind you of is that what you may find when you're doing a first contact with somebody and you've decided to use SPR is that what the person is bringing in with might be things where we do need to refer out. Places where we might do that is that we might find that somebody's primary concern is in fact a physical health concern. And for many of us, that might be outside of our role. And so we're going to want to know how to refer, where to refer. Similarly, we might find that people have immediate safety or practical needs that we're not able to speak to, that we're not able to help them with. And again, we're going to want to know what our resources are so that we can make good referrals, because SPR isn't something that's able to solve all of those kinds of issues. We also talked about the fact that if somebody has acute psychosis or cognitive impairment, or an acute mental health disorder, this is also a place where we'd either want to make a referral, or if that is within our skill set, a place where then we would switch over to actually treating those issues. So again, similar to what we talked about with PFA, it's really important to know resources, right? So for Michelle, Emily, and myself, Molly, you're here. We're giving you the shout out because we have to. It's what we do every time we do this. Molly is one of our go-to resources because she is a person who is that natural link between lots of services within the community, for us within the UW Medical Center, and places that we can go to when we can't solve it ourselves. And so again, with SPR, if it's within your scope, you work with it. And if it's outside of the scope, you got to know your resources. Assuming that we've got presenting concerns that actually fall within our scope and fall within what SPR can help with, from there, what we want to move to is actually prioritizing, right? And so working with the person to figure out what is most pressing, what is most important. And you'll see on the slide an example of different kinds of questions that you might ask someone where you're working with SPR. And ways to think about it, right, is that which of these areas are the ones that are bothering you the most, right? And really thinking about and asking a series of questions of how do we target ones that are potentially causing the most distress, if there's something that we need to deal with first, because if we get it out of the way first, it will actually help a whole lot of other issues that are also part of the plan. Sometimes what we find is that we need to pick a problem that the person might be more comfortable working on first. And if they see that they can get some benefit from it, then some of the other issues that are coming on would be helpful to focus on afterwards, right? And so as we go through these kinds of questions, then we're constantly touching back with the individual that we're working with about, as we take all of these things into account and we understand what SPR does and what you're facing, what's the area that you'd prefer for us to focus on today, right? And so this idea that it really is this collaboration between you as the person providing SPR and then the person coming in with you who has his or her their own sets of concerns. Once we've got a feel for what the individual's coming in with and what their biggest concern are, from there, what we want to do is make an action plan, right? And then based on that, we're going to pick the appropriate SPR skills that correspond to those concerns that the person is bringing in with us. And I'm going to show you an example of how we do that in just a minute. And from there, we also give people a feel for the number of meetings tentatively that we think we're going to have to be able to address the presenting concerns. And we're also looking out again for any referrals that might be needed. Sometimes what we find is that we're going to be doing with SPR a blend of things where we're going to be meeting with the person, providing support through SPR, and then we're also going to be referring out for additional issues that are coming up on that are going to be outside of our scope. As I alluded to earlier, one of the things that happens with SPR is that we really want to match presenting concerns with specific skills. What you see on your screen right now is a screenshot of a handout that we have for all of you. This is part of SPR, part of the manual, and part of what we're going to ask Molly to send out later today. And it's a way to match people's presenting concerns with the skills in SPR. So for example, if somebody comes in and they say they've got a difficult problem, but your sense is that it's solvable, the primary skill that we would be using to address that would be problem solving. There's also some secondary skills that might be helpful to that person. For example, helping with their social connections or helpful thinking, and those might be skills that you pull in as well. A second example is that somebody might come in and say that, they're really being troubled by reminders of what happened. If we think about people who've been healthcare workers who've been part of the surges that have happened in different places throughout the state, they might find that they're having intense reactions when they're being reminded of what happened. And so again, in that kind of circumstance, we would think about initially targeting those reactions and teaching them skills to manage those reactions. And after that, we might consider teaching some secondary skills like social connections or helpful thinking. And so again, you'll see this chart and you might think about it a little bit akin to an algorithm of based on the set of circumstances that someone comes in with, this is going to be your flow chart that's going to give you direction on where you go and how you can actually help people in such an efficient format. So I want to start walking you through the different skills that come up with PFA, and I'm going to walk you through the first couple, and then I'm going to hand this over to Emily, and she's going to take us through the rest of our time today. But I want to show you what these skills look like and how you would actually teach skills to somebody where you're doing PFA. And the first skill we're going to teach you about is problem-solving skills. And so how is it that we can teach problem-solving skills efficiently in the context of PFA? And just to get us thinking about that and give you some examples of when you might use problem-solving skills, you might think about situations where an individual comes to you and they're talking about how overwhelmed they are by all the things that are going on in their life, that they feel really hopeless after what's been happening with COVID and the pandemic, that they find themselves feeling really demoralized about what's happening, and they just notice and have this sense of, I feel like I don't have control. When you hear these kinds of situations, this is a place where problem solving can be really helpful. And so the case example that we're going to work through today is somebody walking in and saying, I just feel really overwhelmed by what's going on. And we'll talk about how you would apply problem solving skills in that context. So again, what we said with PFA is that one of the things that's really important is we're really explicit, right? We take this coaching kind of role with the individuals that we're working with. And so as a result of that, we're explicit about why we're going to teach problem solving and how it helps and how it fits and would be useful in the context of what they're experiencing, right? And so what we think about with problem solving is that teaching people a strategy and a way to resolve problems that seem really overwhelming is a way to reduce that sense of overwhelming. What you see on the slide here is some example language that you might use with an adult who would come in and talk with you about being overwhelmed, right? And a reminder that when people have been through and experienced a crisis, that it's common, that it's very expected, it's typical for people to be overwhelmed. We want to let people know that problem solving is a skill that they can learn, right? Some of you may be familiar with material, with constructs such as mindsets, right? And that when people have the sense that something is a skill that can be taught versus an innate talent, it builds optimism, it builds hope, and frankly, it's also accurate. Problem solving is something that you can learn, you can get better at. And we let them know, here's the way we're going to do it. The problem solving strategy that gets taught in PFA consists of 4 steps. We want to teach that to the person. And the reason that we want to do it, right, is that it can help them come up with solutions to what they're facing that are just frankly better. They're practical in some ways, they're useful, they're solvable. And in doing that, it can actually help the person's internal experience. It can help give them an improved sense of control. It can improve their sense of self-efficacy. It can make them feel like they've got more agency going forward. So how we do that and the way we actually teach problem solving skills in PFA, the first step is actually to define the problem and decide ownership, right? And so these are skills that many of you with your background in mental health and in doing mental health interventions know already. But right, our very first step is to make sure that we have a sense of what the problem is concretely, right, and in detail. And so for our healthcare worker coming in this particular situation who's feeling really overwhelmed, and we find out what they're feeling overwhelmed about, it turns out in this situation that the person's working really long days and can't get their notes done, and they're feeling exhausted and overwhelmed. The person talked to their supervisor about it, but they don't have the coverage to be able to cut back, right? So this is part of the problem. What we notice also is that this is a problem that can be complex. And so what we want to do is to help the person break the problem down into concrete chunks and pick one part of it to start with, right? We want to be able to help the person make progress on the problem. SPR doesn't expect or need you to help individuals with every single part of it. We need to start helping the person make inroads into the problem that's happening so that we can get them functioning again or establish some skills that might be new. So for this particular individual coming in, what we find is that it turns out getting the notes done is really the place where the person wants to start, and that's a place that's the most helpful versus some of the other issues that the person mentioned, like working 12-hour days, lack of support from attendings, or feeling exhausted. From there, what we want to move into is actually deciding ownership, right? And so a key piece when people are coming in and feeling overwhelmed, and many of us have had this experience with our psychotherapy clients or medication management clients, people come in and they just give us a whole host, here's the basket of problems that I'm experiencing. And one of the things we often notice is that sometimes the issues that are coming up is not actually a problem that that individual can solve, right? And so we want to make sure that we're clarifying and model this to the person that we're working with about who is it that owns this problem, right? So for getting notes done, is this something that the person you're working with actually has that problem, or is it a problem that someone else is having? And if it's a problem that someone else is having, doesn't mean it's not important, but then it's something that we're going to deprioritize and really be clear that this is someone else's problem who needs to work to resolve it versus something that this person we're working with right now has control over. That's where we want to start and work on things in the context of PFA. From there, we want to set the goal, and we want to make sure that we're really clarifying what the outcomes are that the person wants, how we're going to move through it. And as we do that, we want to get a feel for what is it that the person would like to have happen. And so you might ask the person to think through what their wants are, what their needs are, what their concerns are, what they're worried about, as a way to get more clarification of what it is that we're going to work on and what's the desired outcome that we're heading towards. From there, we want to do some brainstorming, right? And again, strategies that we recommend, and we recommend that you be really specific with the person you're working with of, okay, now we're going to do some brainstorming. We want to write down all the options, right? What we're looking for typically with PFA is as much as possible to have 5 to 10 possible solutions. Sometimes that's not always possible. And again, this is a place when we think about this is a brief intervention, it's a directive intervention that we're doing. This is a place where we're really looking for the interventionist to step in if the person is getting stuck. Ideally, we want it coming from the person you're working with as much as possible. And when people are overwhelmed, they sometimes have a hard time getting started. And so it is that balance between we want the person to lead as much as possible, and we want you to feel empowered to step in when you need to help brainstorm and come up with additional possibilities and options. Once we've got our set of options from there, what we want to do is evaluate and actually go through those different options that have been presented and look for the best solutions, right? And so one way to do that is to really look at the pros and cons and have the person think through, based on the set of pros and cons with those different outcomes, what seems to be the most feasible, what seems to be the most useful solution. What we typically find and what we're looking for as the outcome of this skill in terms of homework and practice is that the person starts implementing the solution or solutions that they find to be the most helpful and the best at this time, and also to be able to practice and use the problem-solving steps for other areas in their life. And so a typical practice assignment might be like, okay, so let's actually have you implement this solution that you came up with, that you want to come in a little earlier and stay a little later. And you also raised this other concern about a situation that's happening with your family. Let's also have you practice the problem-solving skills exercise in that domain and see what it's like for you to be able to break it down into some smaller pieces, come up with some different options, figure out what your goals are, and then evaluate the best solution possible, right? So we're thinking about both as a strategy. From here, we move into our second core skill, which is promoting positive activities, and I want to walk you through that. This is a skill that we tend to use when people are coming in and they're really talking about feeling a lack of pleasure, a lack of positive mood in any way, a lack of mastery in different areas of their life. So for example, somebody coming in and talking about that they're feeling down, they don't feel excited about things anymore. People may also talk about disruptions in routine, right? Their routine's gone out the window, they don't have a schedule anymore. And people might even notice that the things that they used to like doing, they're just not getting to do or they're not able to do right now. And so here we're going to really think about, in our case example, a person who's saying, you know, I just feel really down and I don't feel excited about things anymore. What we want to do then is to really figure out how we can get some more positive activities into the person's life. And the reason why we do this, again, remembering with PFA, we always start with the rationale. Why is it that we're going to teach them this skill? Is because positive activities actually improve mood and give people a sense of control. For those of you with a cognitive behavioral therapy or a CBT background, you'll notice that this seems an awful lot like behavioral activation. I would say this is behavioral activation light. This is a quick and dirty implementation of that. And what we think about, in a way that we might talk about this rationale with our with people where we're doing SPR, is helping them think through, right, what the implications are of a crisis, what happens in a crisis and the aftermath of a crisis, and helping people realize that what crises often do, typically do, is that they screw up our routines. And when our routines get screwed up, when things are really stressful, we end up feeling bad. And we want to help people understand the implications for that, is that it makes it even harder for them to feel good. It makes them harder for things to do that are important to them. And that when that happens, our sense of purpose, our sense of control, our sense of pleasure can really get disrupted. And so by implementing and really thinking about positive activities, what that can do is actually help us feel better. It can improve mood, and it can really, really restore a sense of control, where for many people, when they're in this situation, are feeling quite out of control and a big loss of control. What we do in terms of this core skill is, right off the bat, we first start off by identifying or planning one or more activities. And one of the things we can do is to actually review with the person we're working with a list of activities. And so we've got an example up here of different types of activities that might come up, things that might be creative, things that might be about doing kindness, doing something kind for other people. It might be doing some planning, it might be doing some writing, or it might be doing some kind of self-care or physical activity as well. And so really walking through that and coming up with what might be useful. And then from there, we want to have the person generate ideas, right? And again, thinking about the entire model of PFA, where we're really wanting to anchor this around people's strengths, their pre-existing strengths and pre-existing resilience that they had, having them think about what are things that have worked for them in the past, and of course, thinking creatively about how might we need to adapt them in the context of our post or current COVID world. From there, what we want to do is actually have the person think about how they would schedule them. How could they actually implement them in the calendar? And thinking about things that they could do that would increase the likelihood that they would do activities. And so if we think about what typical homework or practice it would be to actually go out and start implementing the activities that you and the individual came up with, and then to continue to identify and plan activities going forward. And so with that, I'm going to turn things over to Emily and have her pick up core skill number 3, which is managing reactions.
Thank you, Kristen. So core skill number 3, managing reactions, comes up in the context of clients that are having a lot of really strong reactions to reminders of something really stressful that happened. So for example, this would be for callers or clients that are having a lot of nightmares about a patient that maybe had a bad outcome. Maybe when they even think about going to the ICU or putting on PPE, they panic. When they think about what happened, maybe they can't stop crying. So really strong, intense, acute emotional reactions to reminders. So for the case example, we're actually gonna consider callers or clients that are having a range of reactions, because typically what you'll see is that a bunch of things related to the event are bringing up these strong emotional reactions. So we're gonna cover kind of people presenting with a range. So as always, we start with the rationale. So basically the core idea here is that feeling your feelings is what's most helpful with reminders. So instead of trying to push emotions away, what we want to do is give people strategies to sit with their emotions or process their emotions in adaptive ways. So what you could say to clients is that it's really normal to have strong reactions to reminders of a crisis or a really stressful event, especially in the first few months after the event. And for most people, those will go away naturally over time, like Kristen said at the beginning. And that something that helps that process of kind of recovering over time is finding healthy ways to feel your feelings about the hard thing that happened. And that over time, using strategies that help you feel your feelings can make people feel more self-confident, they can improve functioning, and they can improve coping strategies. So the first step in managing reactions is to identify what actually the distressing reactions are and what is triggering them. So what things are happening that are eliciting these reactions. So potentially they're having nightmares about a patient, or like I said before, they're having nightmares, they're having panic attacks, and they're thinking about going to the ICU and they can't stop crying. So the first piece of this is to help them pick the reaction that's most distressing. So maybe it's repeatedly crying whenever they think about what happened, because that maybe is impacting a wider range of pieces of their life. So then what you do with that reaction is then discuss the triggers for that specific reaction. So when is this coming up for them that they can't stop crying? So maybe it's when they watch the news or watch COVID-specific coverage of the news. Maybe it's when they talk to their friends because their friends tend to ask them how work's going. Maybe it's at morbidity and mortality reviews that they can't stop crying. So it's even coming up in a work context. So then what we then focus on is implementing skills when these triggers occur and these emotional reactions occur in response to the triggers. So the first skill is a breathing skill, and I'm just going to be quick with this because we already talked about it in the context of psychological first aid. But the essence of the skill is to get comfortable, try to breathe in through your nose, out through your mouth, maybe even putting a hand on your belly to expand your belly to focus on diaphragmatic breathing. And you would want to breathe in for 5, hold for 5, and then exhale slowly for 7 while you say a soothing word. The next skill, and this one is new to skills for psychological recovery, which is a writing exercise. And this one is a way to process some of the negative thoughts and emotions without trying to push them away, but in a more constructive way than just sitting around and ruminating about it. So in this one, we'd have the person set aside 30 minutes and then write about whatever is distressing them for the whole 30 minutes. And while they're doing it, we would really encourage them to give themselves space to feel their emotions, so that it's not bad to cry or feel anxious or upset when you're doing this. The idea is to elicit those emotions and sit with them. And then also to consider the things that the person did to help themselves or others. So it's not just focusing on what they feel they did wrong, but also on the ways that they coped well. And then over time, we would ask the person to repeat the exercise. So maybe the next day or in a couple days, again, set aside 30 minutes and repeat, but this time building in new and more helpful thoughts. So then once we have some of these skills taught, the next step would be to create a plan to manage a distressing reaction. And so what we would suggest here is this in part a preemptive approach, where you're practicing really good and culturally aware self-care to reduce reactivity to triggers. And so this is going to differ from person to person depending on what feels good for them in terms of self-care to prevent reactions. But part of it is making sure that they're meeting their basic needs. So eating regularly and well, sleeping on a regular schedule, getting their health needs attended to, regularly doing positive activities along the lines of what Kristen was talking about a bit ago, and also talking to social supporters when they're stressed out. So again, this is sort of a preventative step in managing reactions, kind of preventing them from coming up in the first place. And I would also just put in a plug for the SPR manual. It has a lot of really good tips for considering the role of culture in all these steps. And you know, of course, we can't get into all of them in this presentation, but it's a really good reference for that. The next part of the plan, once you've kind of tried to reduce the degree to which these distressing reactions are coming up, it's important to have a plan to then deal with triggers and reactions as they do occur. So part of that can be helping the person remember to differentiate between the trigger and the event in the past. So it can be when a trigger comes up, you could feel like you're back in the event and reminding yourself that is in the past, that this is a safe instance. It's just bringing up emotions, and the emotions themselves are uncomfortable but will not harm the person. It's also potentially something they can do is use the helpful thinking core skill, which I will talk about in a bit. And then finally, they can set aside time to even do the writing exercise when a trigger does come up. So maybe just right there and then writing down how they're feeling. And then finally, it's important to also plan to give yourself time to recover after the trigger. So you might suggest that clients use the breathing skill or practice some other relaxation exercise, whatever is usually helpful for them in relaxing. They can again try to do a positive activity, or they can check in with social supporters about how they feel. The next core skill is promoting helpful thinking. And this core skill comes up when you have a client that is saying that they're thinking a lot of things that maybe aren't 100% true and are leading them to feel a lot of negative emotions. So things like, I'll never feel better, maybe it was my fault that somebody died, or that they should have done more, that all of their efforts, or all of the, the medical community's efforts were for nothing. So for this case example, we're going to focus on a client who's saying all of our efforts were for nothing. Again, we're going to start with the rationale. And the key here is that thoughts are changeable, and changing your thoughts can change your mood and prevent or help deal with strong negative reactions. So what you can say is something like, having negative thoughts related to these really stressful experiences is really normal. And for a lot of people, having those negative thoughts leads them to feel negative emotions or have uncomfortable bodily reactions. So I'd like to show you a few steps to help you notice and challenge those unhelpful thoughts. And this is a way to help you change your thinking and help improve your mood and your bodily reactions. So the first step here is identifying unhelpful thoughts. And what you want to get across is that it can often feel like painful emotions arise directly out of a situation. But when you stop and ask yourself what thought goes along with that situation and the emotions, you will often notice that there's actually thoughts that are in between the situation and the painful emotion. So a bunch of different people could be in the exact same situation, and because they have different thoughts, they're going to have different emotions associated with it. And because of that, we can't, so we can't change a situation, but we can change the thoughts that we're having to have different or less intense emotions. So for example, in this case example, so maybe they have the thought our efforts were for nothing whenever they see a news story about COVID cases going up. And so you can help them identify that those are the sort of events that bring up these thoughts, and then help them identify what the negative emotions are that they're feeling as a result of those thoughts. So maybe in this case, it's despair and sadness. And then the next step is to try to identify more helpful thoughts. So you can ask yourself questions. This is, I should say, pretty similar to what we talked about in psychological first aid. So things like, what would be a more helpful way to think about this? What would I say to a friend in this situation? Or even, what do I have control over in this situation? So maybe if you go through this with this client, this person says, well, it might be more helpful to notice that some of our efforts did help save some people's lives, even if we couldn't save everybody. And that it is really stressful that kind of things are going back as they are, but I can't control other people's behavior. And worrying about it doesn't change that. And in doing this, what a lot of clients will do when they're first learning this process is they'll just sort of say the opposite of the thought that they were having. So they'll say something like, I will be fine, or things really aren't that bad, or our efforts did help, completely and totally. And those thoughts don't work very well because they're not convincing, kind of like the negative thought itself isn't true. Just the opposite positive thought often isn't true as well. So it's important to identify thoughts that are true, because oftentimes those thoughts will lead to less intense negative emotions and will be more convincing. So then once you've identified more helpful thoughts, the next step is rehearsing those helpful thoughts. The first piece of this is in your session together, you can have the person imagine the trigger situation and then say the helpful thought out loud. So maybe they imagine watching a news report where they're talking about cases going up, and then they say to themselves, I can't control other people's behavior, and my efforts did help save some people's lives. So then once they've done that, the next step, and this is something you can assign for homework, is the next time you're in a trigger situation, practice the thought. So maybe they can make a plan to watch the news, or just the next time they do end up watching the news and they hear about cases going up, again, saying to themselves, I can't control other people's behavior, my efforts did help save some people's lives. Okay, so the next core skill, the last core skill, is rebuilding healthy social connections. This core skill comes up for people that are expressing kind of interpersonal or social concerns. So things like really missing their family, really wishing they could do more to help other people, people that need more social support than they're getting in the moment. And for this case example, we are going to focus on somebody that doesn't have anybody to talk to when they're stressed, I believe. Yep. Okay. Go to the next slide. Okay. So for the rationale, what you would want to tell people is that when you reflect on the support that you have, it can help to kind of take stock of that support and ensure that you're getting your needs met wherever you do have needs. So you can say something like, for a lot of people, social support can really be a source of strength after a crisis. And so to make sure that you have that social support, it can be helpful to reflect on what your resources are right now with regard to social support, and also where are your areas of need. So I'd like to go through an exercise together to help you reflect on this. And I really think this can help make sure that you're getting your emotional needs met as well as your practical needs met. So the first step is to make a social connections map, and you can literally draw this out on a piece of paper. So maybe ask the client to think about all the people in their life that they consider to be sources of support. So write down their first name and their relationship to the person. And so maybe this particular person has a couple of friends who are really important to him, as well as his girlfriend, his mom, his sister, and a coworker. So then what you'd want to do next is ask the person to look at that map and identify who their most important connections are right now. So maybe this person looks at his social connections map and says, okay, my friend Robert and my sister Kathleen are the ones that are really my kind of core sources of support right now. And then consider who can you share your feelings with? So who do you feel like you can go to and will be really supportive if you need to talk about your feelings? So maybe this person identifies his sister Kathleen as that person for him, and you can pick more than one. And then the next question to ask yourself, or have the client ask themselves, is with whom do you want to be in touch in the next couple of weeks? And this piece is important because it links this social connections map to kind of short-term steps that they can take to maintain their social connectedness. So maybe this person identifies their friend, girlfriend, mom, and sister as people that they want to make sure to be in touch with in the next couple of weeks. And then finally, ask the person to reflect on who might need your help or support right now. And the reason that this is important is because in part, we obviously relationships are bidirectional. And so it's really important when people are stressed to make sure that they're still keeping an eye out for the needs of the people around them. Because in part, that's just being part of a good community member and can make them feel a sense of connectedness and purpose and just sort of positive emotions generally. But also because giving support can be a way to make sure that you're getting support. So if they check in with Reggie, maybe Reggie then follows back up with them later on and make sure that they're okay as well. Then the next step is to consider who and what is missing or needs to be changed. So maybe in reflecting on this map, this person notices that their coworker Jen is important to them, but they haven't really been in touch with them, and Jen didn't get identified for any of these things. So maybe this person realizes that they need to reach out more to Jen. Maybe this person also notices that they only have one person that they really feel comfortable sharing their feelings with. So it might be important to identify somebody else or cultivate another relationship where that might be possible. So then once this person has taken stock of their social connections map, the next step is to make a social support plan. So maybe this person's going to reach out to Reggie to support him, try to check in regularly with Kathleen, Robert, Jamie, and Luz, talk to Kathleen when he's upset, and then reach out to Jen more, maybe with the idea of Jen maybe being a person that one day they'll be able to share feelings with in a more open way. Okay, so that is the core skills. So I'm going to transition to talking about some last thoughts as well as some resources. So bringing it back to what Kristen talked about at the beginning, managing acute stress is a way to promote long-term resilience. And so the idea was with SPR is intervening not to get rid of distress, but to build people's capacity to face crises with levels of distress that are tolerable. So I think about this almost like flattening the emotional curve. Like we talked a lot at the beginning of this crisis about flattening the curve in terms of healthcare resources, but we also want to do some flattening of the curve in terms of distress. So we want to think about sort of the optimal level of distress being kind of a moderate level in response to a crisis. We don't want to have no distress because that wouldn't fit the situation, but we also don't want people to have such a high level of distress that it's impairing their ability to cope effectively. And, yeah, we can go to the next slide. Thank you. So we came across this quote that we thought was a really good reflection of what we're thinking about in terms of what it means to be resilient. So it's to be adapting and accommodating rather than resistant to the suffering. I think that's what it is to live through hardship for sustained periods of time. So again, it's not that we want to steel ourselves against the suffering and not experience any of that ourselves. It's that we want to be able to adapt and accommodate effectively when we do experience difficult circumstances. So at the end of this presentation, we've included a bunch of links for different resources, including the field guide, which is the SPR manual. There's also an online training for SPR available through the National Child Traumatic Stress Network that's linked on here. There's also a UW Department of Psychiatry page for COVID resources, which you might have come across already, but we're going to be posting the slides and resources for this presentation there. And then finally, we wanted to let you know about a This American Life episode about COVID in Detroit that's relevant to a lot of what we talked about here and might help get you thinking about some of the aspects around resilience and how to intervene and the kinds of things that people you're working with might present with. So before we switch to questions, I wanted to show you some of the resources that we've developed for you to use for SPR. So the one on the left is a version of the one that Kristen showed earlier in the presentation, and this is a tool for you to help select skills. So the left column includes the concern that somebody might be presenting with. The middle column is the skill that we would suggest as the go-to skill. And then if that one is not appropriate for some reason, or you've already gone through that skill and you need a different thing to work on with a person, we've also included some secondary skills. This is a version of the worksheet developed by the National Center for PTSD. I should also note that at the top of each of these resources, there's a link there's a shortened link to the National Center's SPR materials. The handout on the right includes a brief summary of each of the 6 skills we talked about. So we talked about the 5 core skills, but we've also included assessment as one of the skills. And then finally, the last resource we developed for you is a cheat sheet that includes a summary of a lot of the information we talked about. So on the left of each piece, you'll see when you would want to use this skill, and then there's a brief outline of what you would do to implement the skill on the right, including some sort of rudimentary exercises that you can do with a person. So this is sort of a quick and dirty outline, a reference guide, but again, there's more in-depth resources via the National Center for PTSD. And with that, I'm going to switch to Q&A. I do want to note that we have a evaluation for this presentation that Michelle is going to be sending out in the chat. But if you have questions for us, please do put them in the chat now, or any other discussion points that you think would be helpful for us to address.
Thanks, Emily. We're just taking a look. And so there's a question that looks like it just popped up about whether or not SPR is appropriate for peer support programs. It's a great question. And I think I'll take a first crack at it, and then I'd be curious to hear from Michelle and Emily about this. I think I would put it in as maybe, and with key pieces that I would be thinking about in terms of peer support programs would be thinking about whether or not there's the capacity to be able to meet with people more than once, right? Because if we think about unlike PFA, which you can do just single shot, get people started, with SPR, you really do need to have enough time to be able to teach some skills, see how it went, do some troubleshooting with that, potentially teach more than one skill. And sometimes the peer support programs only allow for a single contact. So that's one place that I would be thinking of around that in terms of fit. Michelle and Emily, what do you think? What else might you think about in terms of that context?
Yeah, I would second what you said. I think a lot of these skills, again, there's a lot of overlap to what is taught in PFA, which we do think is really appropriate for the peer support program. So I think there are ways to try to go through pieces of these skills, even in a single call, but whether that sort of counts as full SPR, I think it would be best implemented in multiple sessions. And so if you have the capacity to do that, I think it would be a good fit.
Agreed. I agree with everything you said. We also had another question come in about this program being really helpful post-crisis, but what about right now, since we're still sort of mid-crisis? And I don't know if one of you wants to take that first, and then I'm happy to jump in as well, but you did all the talking, so why don't one of you chime in first?
I can chime in. So we do think about, there's a sort of point in the crisis where either PFA or SPR might be the best fit. So we think about SPR as being the one that is most appropriate kind of at the tail end of a crisis or immediately after a crisis. But we do think that a lot of these skills, I think, given that this crisis is going to go on for a long time, a lot of these skills are really appropriate for kind of long-term coping with a crisis. So for example, building problem-solving skills is something that you can implement really at any time in a crisis. Promoting healthy activities, especially if the quarantine starts again, or we're still in kind of a long-term restricted period of activities, I think it will actually be especially important to make sure that people are promoting healthy activities. So I think, for most of these, I think it is appropriate to implement at this point in the crisis. And I think something like PFA is more appropriate if the person themselves is having kind of an acute kind of surge for themselves. So maybe they have a relative with who's ill with COVID, or maybe they're kind of right immediately after some really stressful event. But in my opinion, I think most of these are appropriate. I don't know if you'd have anything to add, Kristen.
Yeah, I guess the piece that I would add is part of why we put the This American Life podcast link on there was to give people a feel for some of the healthcare workers who are front lines in Detroit and what the impact has been on them in terms of working with COVID patients and being in that. And so if we think about things like the COVID support group that Molly's running through UW, which I realize is not everybody in the group, but certainly for some people here, thinking about being after the surge, right? When things start to slow down, where that real acute phase has gone down, and then people are kind of left with, oh Lord, what just happened? And it's a different set of skills of trying to make sense of things and how do I move on from that and get back to work on that end. Even though COVID is still happening, that real surge part of the crisis is over, and that from that context, SPR can be really helpful at that point in helping people adapt and move through it and practice the skills. And as somebody who does a lot of PTSD treatment, we used to really have these big questions about, man, can we treat people for PTSD if the trauma is still ongoing? And what we've learned is that, yeah, you can, and it's actually really helpful, and it can help build resilience going forward. And so I think similarly, if people are out of the peak of the most acute phase, it's not necessarily a crazy thing to do in terms of thinking about implementing SPR there, so that you're getting people when they've got that break, when they're ready to work on it. I mean, they're coming to you, you're not forcing them to do it, and that they can bring those skills in, realizing that we are going to have multiple surges, and that it may actually be protective for the next time that surge comes in. Michelle, anything else that you'd add there?
No, I think just kind of similar. I'd echo a lot of what you said around, we really have this period of like increased stress that we're going to have for a long time. But that's going to be punctuated by these periods of like really increased acute distress, as we were talking about at the beginning. And so I think when we think about SPR, sometimes the best time to get it is sort of when the acute stressor has come down and individuals are having time to process what has just happened, but also prepare for the next possible increase, right? And so, you know, we can implement these skills, and we can do so in a way where we set them up to have a plan to be able to use them should kind of the distress get activated again, or the situation get worse again, as we sort of expect it to do, ebb and flow over the next, you know, period of time. And so I think in some ways it's really perfect for that, because these are skills that we, you know, we don't say do it once and you're better. These are skills that we want people to learn so that they can continue to use them as needed. And we're all going to need these skills over the next year, let's be fair, at least. And so I think it's really kind of pretty helpful for that, I think. I think this also ties into the next question, which is, what about when you're working with someone who has a lot of chronic stressors? So would you use SPR, or would you modify SPR for someone who kind of lives in a state of chronic stress? So the example that was given is parenting a child with a significant disability. And I'll just chime in real quick to say that I think you know, a lot of what we just said sort of applies there as well. So, you know, if you have someone who kind of lives in the state of high chronic stress for whatever reason, but they have this period, you know, they have something happen that really is haunting them or really increases their acute distress, you know, teaching SPR skills that they can then apply going forward can actually be really protective. And so I think I would use it very similarly, potentially, with just some modifications of, like, you know, setting the person up to understand when they're going to need to intentionally pull out these skills and really use them, or plan for that. Emily and Kristen, what do you have to add to that?
Yeah, I think I would just add that these are sort of general skills that we know to be helpful in a range of circumstances. So these are very similar to the skills that we use to treat you know, pathological depression or anxiety. It's just sort of more intensive versions of these. And so I see them as being useful, you know, with adaptations to fit people's specific needs and their culture for a really wide range of presenting concerns, because there's so much evidence that they're helpful across a lot of different circumstances.
The next question was around, if we find someone we see as suited to SPR, is there a list of available providers that they can refer to? Unfortunately, no, not that I know of. You know, Molly, though, might, you know, she'll have the list of people who attended this training for sure. So I don't know if there's any way to sort of get that in place. I don't know, Kristen.
A couple things I would say is I would reach out to Molly as a place of people who would have some basic background where they could do it, and think about places. I know as we think about dissemination and implementation, we're going to be working with, for example, the psychology and psychiatry residents through UW to roll this out and to get people more background in this. What I would also say is that HATC, formerly known as HCSATS, through Harborview, there are providers there. There are fabulous providers. I think some of you may be on the call today. They have been doing essentially versions of SPR for a long time, and they're a wonderful group also as a place to refer to as well. And I think the place where I want to encourage you, because I see some questions about, you know, who can teach SPR, how do you go through to qualify? You know, if we think about how we typically roll things out in the context of disasters and crises, we're typically rolling things out very quickly, very efficiently on that way, and often in this kind of scattershot, let's just get it out as fast as we can. I think it is a place of really going back to and thinking about, you know, most people, there isn't a formal process to get certified. If it's something that you're like, hey, I'd like to try this, I think I could do it, it's a place where what you might think about doing is going and reading the manual, doing parts or all of the SPR training that the National Centers does as a way to dig into this a little bit deeper. They even have some CE that you can get that goes along with it as that end. Because for many of you, you may notice I do a fair amount of these skills already. It's giving you an overarching framework and a conceptualization about how to do it, and how to do it briefly and efficiently, and potentially more directively than you may be used to working with your own clients or patients.
We had a question about, what about for someone who doesn't necessarily recognize their own subjective distress, but might benefit, so they don't necessarily see the, you know, the reactions they're having, so they kind of need to be sold on it. Kristen or Emily, do you want to go? I mean, I'm happy to jump in, but feel free to go ahead.
I think it depends on the context where you're interacting with that person. So if it's in a clinical setting, if they're coming to you with some sort of distress, potentially framing it around that and talking with them about their goals for seeing you in the first place. If it's somebody outside of a mental health clinical setting, what you can do, or what I suggest, and Kristen and Michelle should chime in on this as well, is that you just sort of note what you're seeing in the person. So like it seems like you really had a low mood for a long time, or that you really are feeling overwhelmed about all these things that you're needing to deal with, or you're having some really distressing reactions that are really getting in the way of the things that are important to you. And just sort of noting that often will open up an opportunity to have a conversation about next steps, and just sort of making the space for people to say, whatever they need to say about that, and talking through that a little bit, and then, saying, we do have lots of resources available for this, or, I'm trained to deliver this, depending on what setting this happens in, and asking people if that seems like something that would be a good fit for what's going on for them.
Yeah, I think the only thing I might add is, as Emily said, it sort of depends on the setting for sure. But sometimes, distress isn't the thing, like that's not the hook, but, you can instead highlight the impairment, for example, like you can highlight the places where it's causing problems. So they don't resonate with distress, but they do resonate with the consequences, how they're currently functioning is having on their life. And so sometimes you can highlight that as well. The other thing I think I find really, really helpful when working with trauma recovery in any form is normalizing like crazy. So just a lot of psychoeducation about common reactions, and a lot of normalizing of like, after really stressful traumatic experiences, this is what we see. We often see like this is expected in some ways, and we have things that we can do about it, and we can set you back on a path of feeling better, or for improving, or however you want to word it, but really kind of validating and normalizing is really key with anything trauma focused or that's geared towards trauma reactions, I think. And it tends to be a really helpful way to get people to buy into a rationale. Specifically talking about how the stress is completely normal, but sometimes we need a little bit of help and a little bit of skills to help work through that distress so it doesn't persist of the long term. So
the other piece that we, because of time constraints today, we didn't include it in the presentation, but it is part of the SPR materials and the formal manual, is that there are screeners that are part of those materials that you can use when you're meeting with somebody. And so if this is a situation where you're concerned about somebody and it's coming up in the context of a professional or quasi-professional situation, meaning from a mental health standpoint or behavioral health standpoint or healthcare setting standpoint, those screeners are something that could come in. And it's also just a way of providing that education and assessment of people looking at this and saying like, oh, here's a whole list of problems that I could check off if they're affecting me. And oh, wow, it turns out a whole bunch of them are things that are happening. I didn't realize that that's part of being affected by a crisis, common reactions to it. Oh, and I didn't realize that there are ways to target that and it could actually make it better. So those are some things that I might think about there. I also just want to send one last shout out. I had gotten one private message about materials, and just as a reminder, we will send out via email a copy of the slide deck. We'll send you a PDF of that so that everyone has it. And we'll also post materials to the department, the psychiatry department's website for COVID-19 so that it's also available there.
So we have a question about suicide prevention resources. Suicide prevention is not explicitly built into SBR because it's sort of, it isn't considered appropriate for people who are at that level of distress or that level of difficulty. And so usually you wouldn't be doing SBR, you'd be kind of referring out. In terms of general suicide prevention resources, I don't know that we have anything on our COVID website and the psychiatry department right now, but I think that Molly does have resources around that and is a really great resource for everything. But certainly I think for this as well. Otherwise, more generally, you know, the King County Crisis Clinic also has some really good resources put together, as well as NAMI and some of the more kind of national organizations. I don't know, Emily and Kristen, do you have other things that you refer to for general suicide prevention resources?
I would think about things like the National Suicide Crisis Line, and that there's been increasing availability for individuals, not just via phone, but also texting, right? To really be able to meet people where they are and think about communication that is most effective for the person who's struggling. And so I would say, you know, you might think about, are you referring out or referring up? If somebody's coming in with safety concerns, you know, SPR is not going to be adequate to address that. You might have the skills, and then you're going to do your go-to skills and use your own clinical background and experience to actually treat the suicidality, or you're going to be referring out. And whatever you would typically do to refer out, those are things that you'd want to have in place. And if part of what you're realizing is you don't have the resources in place, then I think, you know, thinking from a systems level, what do we need to build in so that we have those resources available, and who would be go-to people, so that that's part of what you would have at the ready if you're going to start doing SPR.
Doing SPR over Zoom, yes, that's a valid question right now for sure. You know, I don't know that there's hugely special considerations for doing SPR over Zoom, other than, you know, the shifts that we have all had to make doing interventions over Zoom. So things like thinking about, it's a little harder to share worksheets, you know, setting up share screen and that kind of thing. As well as, you know, it can be a little hard to connect to people, especially if you're only meeting, you know, someone 2 or 3 times. But I think, you know, in terms of the general things that we do when we're doing therapy over Zoom, I'm not sure that there's anything else specific for SPR. And we do have a ton of data now that we can do PTSD treatments. You know, Kristen was alluding to the fact that that's a lot of what we do. And we can do PTSD therapies that are like much more intensive PTSD therapies, like prolonged exposure and cognitive processing therapy. We can do those over Zoom successfully, or I should say over telehealth. It's not always Zoom, but via telehealth very successfully. And our outcome data actually doesn't show any significant differences between delivering those PTSD interventions via telehealth versus in person. And so I think that really I think that gives me a lot of confidence that something like this could certainly be done as well over Zoom.
You know, a news.
And then the last question we have is about, can this
you have a new stressor in
the last question that we have has to do with whether or not this training can take place in groups as opposed to one-on-one. And I assume you're thinking about applying to clients in groups, or a group full of clients.
What was the backup plan?
As opposed to the training in the therapy. So, you know, I don't know if there's any there is no established literature on doing SPR in groups. I know that. I do think that it's being done though. So I do think that people are trying out those models, similar to what I think we had this question on PFA as well. And we do have some colleagues who are implementing these kinds of really early acute resilience building interventions in groups successfully. I don't see any reason why we can't do SPR in groups. I think some of it is about figuring out how to not lose that tailoring to the patient or to the person seeking SPR, because it is supposed to be tailored to their specific concerns and their specific needs. And so you have to find ways to do that in the group setting. But the skills that are encompass SPR lend themselves very well to a group setting. And again, we can do general trauma treatments in group as well. Thank you. So Red Cross and teach PFA in groups all the time. Absolutely. So that was my understanding, is that these models are often done in groups. I think the one caveat is that the thing to avoid in a group setting is processing of any trauma memory details. So it's not helpful in groups to really get into kind of the very specifics of the traumatic events or stressors that people lived through. We've actually found that can be unhelpful to hear somebody else's specific trauma details. But other than that, as long as it's kept very skill-based and any trauma memory processing is done outside of the group setting, one-on-one, I think it blends itself really well. I don't know, Kristen, Emily, do you have anything to add there?
Yeah, I would just say that I, along with HATC, run, well, before everything happened, where I was running bi-weekly skills groups for people seeking PTSD treatment on their wait list. And those skills groups weren't explicitly based on SPR, but look a lot like these skills. And so we just really kind of emphasized that it was a class rather than a support group, and focused on kind of, you know, a lot of the rationale. So it's normalizing and explaining how these skills can be useful, and then just teaching skills and kind of talking through how to practice skills rather than doing a lot of the kind of more processing like emotional support of specific people that would happen in a more classic support group. And I think that it worked really well and people seem to really like it. In fact, a lot of people, once they started therapy, said that they felt better more quickly because they had already been implementing the skills before therapy started. So that's just sort of an anecdote. We don't have any research on that, but that seemed to have been going well.
And last thing I would say is just if you are on this call and you do end up implementing SPR in groups, I think we'd love to hear how it goes. So definitely, you know, as Kristen mentioned earlier, or Emily, I can't remember, but we're learning as we go, and these things are rolled out very quickly and adaptations are made very quickly. And so certainly report, you know, we'd love to learn from you as well. And if you're doing it in these different settings or trying these different adaptations to some of this stuff, you know, we'd love to hear back from, you know, how it went and what that experience was like. So the next time someone asks that question, we'll have some additional data to answer with. So that looks like all the active questions we had in the chat so far, but we now have about 3 minutes left. So if there's anything else, please feel free to chime in now. We're happy to try to answer it. Thank you so much for your time. We really appreciate you being here. We know it continues to be a really busy and stressful time for many of us, so we really appreciate you investing in this. Yeah. Any additional last minute comments or questions, Emily or Kristen?
Just one last plug to please take the evaluation survey. We do take that feedback really seriously, and this is the first time that we're trying out this particular version of the training, so your feedback would be really helpful.
Great. Well, I'm going to stop the recording.